43-year-old man with a history of chronic alcoholism presents with chronic cough and dyspnea. He says that he traveled to Asia about 4 months ago and his symptoms started shortly after his return. His temperature is 104.4, his pulse is 92, physical exam reveals poor personal hygiene and cough productive of foul blood-streaked sputum. Auscultation reveals decreased breath sounds on the right. A chest radiograph reveals an ill-defined circular lesion in the right middle lobe. Which of the following is true regarding the patient's most likely diagnosis? So what do you think is the diagnosis, and what would we do about it? So stains of gastric washing and urine have a high diagnostic yield on microscopy. Inoculation of a sputum sample in selective agar media needs to be incubated at 35 to 37 for 8 weeks. The Zn stain is more sensitive than microscopy. The DNA PCR has poor sensitivity when applied to smear positive specimens, or a positive tuberculin test would be diagnostic of active infection. Okay, so this was a straightforward question of TB, nothing complicated happening here. So this patient's history and physical findings are strongly suggestive of TB. Patients with cavitary TB present with chronic productive cough, which is rich in tubercle bacilli, in addition to hemoptysis, chest pain, constitutional symptoms. The gold standard is culture and selective media, which would be the LG media or the Middlebrook medium, and it should be incubated at 35 to 37 for up to 8 weeks. So it's got a very, very long incubation period. If cultures are negative at 8 weeks and infection is still strongly suspected, then you incubate it at a longer period and at a lower temperature and for a longer period. So once again, this diagram is just summarizing some of the main features of infection, which would be appetite loss, fatigue, chest pain, cough with hemoptysis, productive cough, night sweats, pallor. Okay, so gastric washings and urine, these are not preferred for the diagnosis of microbacterial infection because they may be contaminated with saprophytic mycobacteria, which can also give you a false positive result. Fluorescence microscopy with the auramine rhodamine stain is more sensitive than the Zn stain. So this question, the option said that the Zn staining is more sensitive, which is false. So that was not the right option. DNA PCR is a rapid test that holds great promise for improving the diagnosis of mycobacterial infection. The sensitivity is 60 to 90%, specificity is more than 95%. So excellent sensitivity, specificity. Sensitivity is highest when applied to sputum that are smear positive. And a PPD only indicates the patient has been exposed to MTB. A positive does not mean the patient has active TB. So that was something to pick up on here. So they said that a positive the PPD would be diagnostic of an active infection, which is not true. It just means that the patient has at some point of time been exposed to the bacteria. Okay, so pretty straightforward, nothing much. TB is not a very commonly tested topic on the USMLE. But just some basics like what is the medium which is commonly used, the fact that it has a long incubation period, these would be some of the few things to remember. Apart from that, really not much focus on TB.
Thanks for watching. Please give a thumbs up and subscribe for more.